Hello, good afternoon everyone. Welcome to this February meeting of the Derby and Derbyshire Integrative Care Partnership. Thank you for everyone who's attending today. Looks like we've got a good attendance. We've got a couple of members of the public, which is very welcome. And I know some of you have to leave early, and thank you for that. So thank you for letting us know, sorry. So do we have any apologies, Lindsay?
Yes, we do. We have apologies from Councillor Heselgrave, Stephen Bateman, Gino Di Stefano, Lee Sharrod is covering for him, Sue-Ann Lim, Alison Noble, Peter Lambert is covering for her, Kathy McLean, Michelle Arrowsmith, and Steve Lismore. That's it.
Right. Oh, right, I didn't know it was working. Yeah, Councillor Natalie Hoy, and I believe Councillor Julie Patton. She was at Matlock, but she didn't know whether she'd get back. Okay.
Thank you very much. There are a few people standing in for other people, and I can't always remember everybody's name, but I do try. So, but on the spur of the moment, it sometimes doesn't come to me. So, if you know, when you speak for the first time, if you wouldn't mind saying who you are and which organisation you're from, please. And also just to remind you that in order so that I can hear you at least, and also this is being cast, so in order it can be cast effectively, you do need to use the microphone and speak to the microphone, and also turn it off when you finish speaking. Thank you very much. Right, we have no late items. Do we have any declarations of interest? No, thank you very much. So turning to the minutes of the last meeting, it was a short meeting. We just had the one item because we then went on to the development day. And apologies we've not been able to hold the meeting since, but I think we had, I can't remember what the scenario was. I think we cancelled one because it was August, and then we had something of a safety emergency in the council house. I think that was right. So none of us came to the council house. That's unavoidable, I'm afraid. So we are here now. Could we all accept that they are, we all confirm those minutes, those who are here at the meeting? Do we all accept them as a good record of the meeting? Yep. Thank you very much. Okay, so I'll move swiftly on then. We've got a few items today. I found them very interesting reading them last night. The first one we have is a report from Nikki Smith, Fiona Colton and Emma Lane on the Startwell update. Thank you.
Thank you, everyone. My name's Nikki Smith. I'm the Assistant Director of Children's Commissioning at the ICB and the Deputy Chair of the Children and Young People's Delivery Board. I'm here today to present the paper that gives a brief update on Startwell and the progress that we're making with the system priority. What I'd like to do is hand over to Emma and Fiona to talk specifically about a recent joint pilot that has been undertaken, so I'll pass over to them. Thank you.
Hello, I'm Fiona Colton and I'm Head of Early Help Services at the Local Authority in Derby, and I'm also the Senior Responsible Officer for Family Hubs.
I'm Emma Lane. I'm a speech and language therapist. I'm the autism lead for Derbyshire Community Health Services for the paediatric team. So we've come today to talk to you about the early years MD pilot project that we've been doing in Derby City. This is something that has come out of the long waiting list that you'll probably be aware of in looking at neurodevelopmental diagnosis. So we've been trying to look at ways that we can integrate some of our health pathways with broader pathways, including the family help, the early help offer and the education system. So our aim of this is to develop a process that provides families with information, support and, where relevant, diagnosis at the right time by the right people. So currently there's a lot of 2-year-olds who are identified at their 2-year check, and historically what's happened is the majority of those children have been referred straight to SPOA once those initial concerns have been raised, and that immediate referral has driven really long waits in the diagnostic assessment system. So we've got this bottleneck of all of these children being referred. So what we wanted to do is to see if we could invite relevant families to a small group and work together between agencies to more accurately guide families along a variety of pathways rather than straight to specialist services. So just a couple of notes. These are literally from notes of the team around the driver for referrals. So people writing in the notes, I've informed the parent it'd be better to refer now than later due to waiting times. Reassured mum, we're here to support her. It's important to make relevant referrals now due to the long waiting list. So you can see clinical decisions are being made based on waiting times rather than actual clinical assessment of need for children. So some of the benefits that we felt we would get from this was a clear pathway linking health, early help and education. A clear message to families that they're not being rejected or referrals delayed, but they're part of a support and information gathering process that may or may not lead to a diagnostic assessment. So what's been happening in the past is they've come through to a multidisciplinary meeting, which is very much based on paperwork, where potentially referrals are not to be taken up, which is seen as a rejection, and then lots of bounce back referrals all the time. So we wanted it to be part of a real information gathering process where we're seeing the right children at the right time. So a timely diagnostic assessment and face-to-face triaging when possible. Being someone who sits in those meetings when we're looking at the paperwork, we really feel sometimes if I could just see this child for a few minutes, we could really make some much better decisions about what they need. So we thought also there would be lots of knowledge and skill share gained from this with the agencies working together, particularly between speech and language and the health visiting team, that we could help with identification of children and timely referral. It would help to engage families with the family hubs. There's lots of really lovely work going on in Derby City with the family hubs. So helping families to come and be part of that process, part of that provision, rather than thinking that they're sitting on a waiting list and waiting for something to happen. We hoped that it would reduce the referrals into SPOA and make more timely assault and paediatrician referrals, which would reduce the waits. If we can get rid of this bottleneck of referrals, then we can bring them in a timely fashion and therefore reduce the waiting list that we've got. And again, quicker access to support and advice and a potential opportunity for joint commissioning. We're really looking at transformation. So we were trying to make this as transformational as possible. So how have we got on? So this is a leaflet that we've been giving to the families. So the health visitors have been giving to the families at their 2-year check. So what they're doing is they're checking in with them at 2 years, as they're required to do. If there's concerns about their child's development at that point, then they are providing them with lots of really good signposting. There's the Solihull programme, which is online. They get signpost to that. Things like BBC's Tiny Happy People, those kinds of resources, which have lots of lovely videos showing families how to do some really nice early interaction strategies with their children. Then a few months later, the health visiting team check in with them again. If there's still concerns, then they guide them to our triage groups. And these take place in the family hubs once a week with the speech and language team and family health practitioners. And then we have a look at the children in that group, speak to the families, gather information. Then one of our usual next steps from that is the early support group, which is in the family hub. Those are great groups which go on. They offer 4 weeks of support coming to a stay and play type session where we've liaised with the family hub around the content of that, and they get given lots of lovely strategies. The children are played with, observed. We see how they interact in those sessions and gather more information. And then after the ESGs, we're getting together in locality meetings again to discuss the children and decide who needs to go forward for a paediatrician assessment at that point. Bearing in mind, we've got lots of lovely information from the system that they've been through as part of this process. And then if not, there are other routes that we send them to, which we'll talk about next. So that's a bit little, but this is the bigger sort of pathway that we've developed around these children, trying to put together the health system, the family hubs and the specialist services. What's happened historically is children have gone straight from universal level. So we've got their universalist just for a few children, universalist for all children, targeted is for some, and specialist is for a few. And what's happened historically is children have jumped straight from universal up to specialist because of the driver of long wait. So we're trying to bring all of the systems, because there's so much lovely provision out there for them, bring that in earlier. What was happening, they would jump into specialist and then down to the provision, and actually we bring the provision in right at the start, front loading, and then the specialist bit is almost just like a touch point later in the pathway. So different outcomes of the triage group could be the early support group, as I said. Some children may go straight through to a paediatrician assessment group. We might advise a watchful wait, which would be via attendance at nursery probably. We've been discussing with education in the city recently. They are going to be introducing an intervention first team, and we're looking at how these children who are watchful waiters will potentially link into that part of education first, get more information, more support, so we can decide if we need to go forward for an assessment again. They may be offered the Welcome to Words programme, so that's more for children who are speech and language delayed rather than neurodevelopmental concerns. There's Understanding Children's Behaviour course, Solihull face-to-face courses. Sometimes we've got children where we feel it's around attachment, things like that. Those sort of courses are more useful for that. So there's a variety of things out there in the city, and that's why we base this pilot in the cities, because they've got the family hubs and they've got a lot of this provision in place already that we could link the health and the education system into to make it all part of one integrated process. So just some initial data here from the first part of our pilot. So we started running the triage groups in September 2024. So you can see some figures here around the SPO referrals. So that's the single point of access for neurodevelopmental referrals. So for 0 to 3-year-olds, in July to September 2023, there were 100 referrals made for that age group of children for specialist assessment with a paediatrician. 64 of those were made by the health visiting team. And the same period in 2024, which was when we started the pilot. So the triage didn't come until September, but we stopped the referrals from the health visitors around July. So you can see there a dramatic reduction in referrals because the health visiting team weren't referring the children straight into specialists anymore. They were referring them to our triage group instead. So you can see we dropped down to 29 children being referred in that time. So children where there are maybe red flags around development that are more medical based will get sent into the SPOA still, so they see a paediatrician when needed while they're young. So in the triage group, 83 children attended between September and mid-December. We're still running those now, but these are the figures at Christmas. And out of those, 20 children were identified as needing a community paediatrician assessment right now. So, or who would be suitable. We had enough information at that point to go forward with that. So you can see there's a significant number of children there who would have been referred. So all of those 83 would have been referred to SPOA, would have potentially been sitting on the community paediatric and speech and language therapy waiting list. And actually only 20 of them need it right now. And then they've been assigned to do other parts of provision that I've talked about, coming back to the possibility of assessment later on. So projected impacts around that, I'm not thinking about the families, I'll show you the impact for the families, but thinking just purely kind of data-driven things, is a reduction in waiting time for other referrals triaged at the MDM. So the MDM is the meeting where the SPOA referrals come to for the community paediatric, clinical psychology and speech and language teams. So there is currently a very long wait even to have your referral discussed, up to a year for some age groups, just to have your referral discussed to get onto a waiting list. So the fact that we are filtering these younger children into a different route means that people attending that meeting have more time to focus on the older children while we're dealing with the early years children. And some projected impact for that is shorter waiting time for assessment in the long term. Certainly these younger children are waiting less time, but the older children should do as well, as we are filtering the children through and bring them in a timely manner. And what the paediatricians are finding is there's a less need for review appointments. What happens sometimes is they're referred very early on. They're not able to make a decision about diagnosis at that point, so they have to see them several times. Whereas because we're using this integrated system, we're gathering lots of information as they go through the process. By the time they get to the paediatrician, there's loads of information for them to use to make their clinical decision. So a little bit of parent voice and impact for families. So this was one family. They'd actually got a 14-year-old who's going through the process as well and is on waiting list. So they said it's been a lot easier and a lot nicer, a lot more of a personal process, looking at each child rather than words on a form. My 14-year-old's going through it now, and it's very frustrating. He fell through the cracks of COVID, and it's a long, drawn-out nightmare. With their child, it feels a lot more involved from your end, more comforting. Feels like you're being helped rather than languishing on a long waiting list. So the next stage of the process is to move into these paediatrician assessment groups. So for this child, we're running those in the family hubs as well. I've been at one this morning. We bring in 3 families. There's speech and language therapy, community paediatrician, and a family visitor from the family hubs. And we bring 3 families in, and then during the morning, more assessment takes place. The paediatrician speaks to the family, does the assessment, and gives the diagnosis if it's appropriate. So some more information. These ones are from the triage group rather than the paediatrician assessment group. So out of 17 responses, which isn't huge, but from 83 children, 88% found the group useful and were clear about their next steps and plan for their child. So we give them something at the end as they leave, which tells them what's the next step for their child. So they said it was great to have health and speech there. Really saw them as they are because we saw them in a group playing. They were really happy with everything. It was explained well, and a particular section of praise for one of our practitioners that was there, because we have time to speak to the families, find out what they need and guide them to the right thing, and they really benefit from that. They appreciate that. Some bits where we've taken feedback on board and looked at different ways of doing things. So we had one family where they were twins who'd got pica, and so it was difficult. They were worried about coming to that group setting and being able to control the environment. So we have since had those children through the diagnostic process in the paediatrician assessment groups. We've got additional rooms that we can accommodate them with if they're struggling with the group situation, and we were able to manage that environment successfully in the family hub ready for when they came in for their assessment. And some looking at localities, we're only holding them at Osmondston and Allenton at the minute, but from April we will be rotating them around different family hubs within the city, so they're accessible as possible. So the paediatrician assessment group started in January, so the triage started in September. These paediatrician assessment groups started in January, so we've had, well, 5 groups now because we've had this morning, but three children in each group, and 6 more groups planned until the end of March 25, which is when this bit of the project is due to finish. So 6 out of 11 families had responded to the feedback survey so far, but 100% of them rated us as a 10 on a scale of 1 to 10 about how they found the process, and 100% said it was useful to see the paediatricians and speech and language together. So again, some bits of feedback from the parents. I enjoyed being seen in a group, wanted my son to mix and play with other children, to know you're not alone in this, there are others in the same boat. We were very happy, it was an excellent time. It's good so I didn't have to attend different appointments. Very friendly, very satisfied, good opportunity to discuss and share feelings. And some more there. It was perfect the way it was. I feel relieved now that I have his diagnosis. It was brilliant, amazing group. We need more support until our children are improved. So we were able to then guide them onto the next pieces of work that they can have. So for example, in the family hubs, there are autism courses set up that are commissioned that the families can move on to. There are stay and play sessions. And then from my services point of view, they're often moving into things like the More Than Words programme with us. So they definitely know what their next steps are. So what we are looking to do is have a full 1-year pilot following this to be able to fully develop the process and gather robust data. To include children, potentially what we're looking at right now, we've actually run out of 2-year-olds in the city, which is great. So it means that the health visitors are not referring as many children as they were. So our triage list that they're going onto is starting to run down. We had a huge volume of children to start with, but actually in January, only 8 children were put on that list. So we're now looking at how we can start to broaden it out further. So the children who are coming into MDM from different routes, into SPOA from the nurseries, for example, so maybe the 3-year-olds, we're looking at how we'll start to filter them rather than discussing them in a paper-based. We're going to start to guide them into our triage group so they can start to experience this process as well. So we're looking to broaden it a little bit. And also looking at integration with the Derby City Early Years strategy that's being consulted on at the minute, and the Intervention First team that they will be developing. And future-wise, we want to be able to expand this to older preschool children. Like I say, we're just starting to push into that now. And to develop it ideally into the county. Certainly, you can see the early data around the impacts that it can have on waiting times and the numbers of referrals coming in. So ideally, we did this in the city initially because we got the strong early help offer to be able to hook into. But we'd love to be able to develop this out into the county as well, look at how we can broaden this and really look at timely assessment, I think, is the most important thing, where we've got good level of information about the children and we can really look and see when they need to be seen for the medical bit, but they've got some really lovely provision around them to support them as they go. So funding-wise, our current pilot, September to March, the speech and language input's been funded by the Family Hub project under the home learning portion, so with a bit of additionality from our service, linking it to our internal social communication and autism pathway. We've been doing a lot of transformation work in the speech and language service. So in the city, for example, this time last year we had 300 children on the waiting list for an autism assessment from our service, our part of the pathway. We've got this right down, so our wait is down to about 4 months currently. It was over a year, and we're down well into double figures now, so we're down to about 90 children on our waiting list. So it's not just the challenge of getting through them on the waiting list, it's about being able to keep up. Every one we take off, another one gets added on. So we've had to get ahead of ourselves with our waiting list to actually bring it down. So that's a huge, it's something like 76% decrease in our waiting list within the speech and language service. So we've linked this together really carefully to do that piece of work. So our input will potentially stop at the end of March if we don't look at the funding, but it's a transformational piece of work, we feel, don't we, Fiona?
We do. So some good news. We have had our allocation for Family Hubs funding for another 12 months, but there's an element of caution here because it's embargoed. But we funded the speech and language part of the work through our home learning strand of the Family Hubs money. And it is our intention, having seen a draft delivery plan, it does look like we're going to be able to continue. So we haven't got to find new projects. So it is our intention that we fund the pilot for another year. I think, let alone the partnership working between all of us really, the numbers speak volumes, but I think there's still a road to go. We felt we needed another 12 months to really confirm what we found, and it is our intention that once the DFE tell me that I can put it on the form and send it back, that's what we'll do.
Right, excellent. Thank you very much. That's a really encouraging report. So the recommendation on the report is just that we note it. Are there any comments or questions? Kim?
Thank you. Work with Fiona, obviously, around the family hubs. Really keen to understand, in terms of that second part of the pilot, how will it link with the neuro hubs that are developed, city and county? Because sort of family hubs absolutely get that. It's really, and also noticed that the how was quite similar to the way the neuro hubs, which again makes sense to me. So from that perspective, really timely and really welcome. Just keen that we join up with the neuro hubs.
Oh, I've put the microphone on, but I'm going to turn round.
Can you speak to the mic, Fiona, please? Because
okay.
Pressed. And also, people won't be able to hear you. They hear you if you speak to the mic, thanks.
It is our intention, as we already do, to signpost into the ND hubs. So the ND hubs are about support, and that's what we're doing. So any parents who want additional support, who may not be at a point where they need, dependent on age, the signposting through from early help, from the family hubs, is direct into the ND hubs.
Any other comments? Chris?
Yeah. So also just to really acknowledge from our perspective how good this is, and two things about it: the fact that the 4 years or 3 years of co-production on the children and young people's neurodevelopment pathway, which was excellent, showed this as a key aim, was trying to bring the services closer to people and much quicker for obvious reasons. And so to see this happening, particularly with clinical services, is really excellent, and it's exactly what was sought in the ND pathway work. So I think the opportunity to take this forward together and wider, which is expressed there, is really good. The second thing is, I'll touch on it under research. I'll come back to it in research. Thank you.
Thank you. So I've got Chris Weiner and then yourself at the back.
Thank you, Chair, and thank you for the presentation. I'm speaking from personal experience with my family about trying to access speech and language therapy services, and I'm so pleased that this work's going ahead. It is deeply, deeply frustrating for families when they can't access services in a timely fashion. And actually, it's hugely important for these children, not only in their early years, but for the rest of their lives, that they gain access to good quality services around speech and language. It impacts on their educational attainment, which carries on right the way through to their teenage years with their GCSE results and their A-level results, and potentially any results beyond that in education. It then impacts on the families they have, because it impacts on their ability to earn a decent income to raise their families within. So hugely important. Thank you so much for driving this quality improvement approach. Really appreciate it, personally as well as professionally. I think it's really important that you do follow up with that further 12-month study and just make sure that you're gaining the results which could actually potentially impact not only within Derby and Derbyshire, but right across the country. Thank you.
Thank you.
Hi, I'm Penny Blackwell. I'm a Clinical Director for Neighbourhood Care. I just wanted to say, and I'm also a GP. So I just wanted to say this is a fantastic approach, and I wanted to endorse for anybody who's a non-practicing clinician here. This is a really difficult period of time, and when you don't know whether your child might have a neurodiversity diagnosis, a speech and language issue, a physical issue, a lot of things are presenting similarly at this age. But what I think is really important that you've done differently, and I would love to see rolled out across the age range and for neurodiversity as well, is that there is a lot of support available, but these are sometimes families who are really struggling. So you've got a pathway in here where, just in case you're using the watch and wait strategy and it's not quite clear yet, that doesn't mean that no help is being provided. This is a group of really anxious parents and carers who make multiple attempts to attend the GP for advice or to attend other services for advice, and actually having that advice put in really early and then followed through and held whilst that diagnosis becomes clear, or the diagnosis isn't a diagnosis and everything's okay, I think is really, really crucial and different to how we're managing a lot of our pathways across the system at the moment. So I just wanted to highlight that as being quite different and really helpful in terms of attendances at GP practices, but also probably mental health of parents and carers who are trying to manage, and obviously schools when we're talking about older children. So thank you for this approach. I'd love to see it rolled out further.
Thank you. Carol?
Yeah, I mean, it's an excellent project, and I think it is important that we concentrate on the people, the ones that really need the help, because we can't help everybody, so I think that is important. One of the things that just cropped up, though, how do you find any complications or barriers where perhaps English isn't the first language? How do you sort of cope with that?
So we're very fortunate within the family hubs that we've got a lot of staff who speak more than one language. And we've also used some of our transformation funding for interpretation. And I think really, from mine and Emma's perspective, it's been about the partnership working, and as well as the right service at the right time, the right people. So where we've got family visitors involved in some of the sessions and they speak a particular language. So you'll notice on the feedback from one of the families They want to move to Rose Hill because they know there are staff at Rose Hill, which is inner city Derby, can speak the language that's their first language.
Can I just add to that? So we have done quite a few things as part of the Family Hub project work that speech and language are part of. There are various early interaction videos that we've produced, that we'd previously produced, but the team have had those translated, and so they're available in a variety of languages, so we can send those out to families. They can watch a little YouTube video, give some ideas about strategies, and it's all interpreted with different languages. And also within our paediatrician assessment clinics and the triage groups, we book interpreters if we need them to be there to support it. We've had particular issues around one quite new language into Derby City, I think recently, and it's hard to get interpreters, but we managed to do that by video for the paediatrician assessment group the other week. It was a challenge, but we got there. And then my challenge was, how do I support this family going forward? We want to go and model the interaction strategies, so our bilingual specialist has arranged for that new language to have all of the videos interpreted again, so we can use those with the family as well. So we're working hard on that.
Thanks very much. So final comment over here at the back.
Yeah, I'm Drew Smith, Deputy Medical Director of the GP Provider Board and also a GP. Carol essentially asked the question that I was going to ask, which was language difficulty, because you don't want that to become an issue that widens health inequalities, so thanks.
Yeah, thank you. And I think it is really important that there is this early help and this triaging, because there must be an overlap between social and medical here. And we had heard at the Health and Wellbeing Board, was it last week or the week before, alarming statistics about the increase in child poverty in Derby. So now we have 33% of children in Derby are now, I mean, I don't need to tell you this, Fiona, but, I don't think everybody knows this, that 33% of children in Derby are now classed as living in relative poverty. Some of those children, Arlington, Arboretum, etc., are living in deep levels of deprivation. So I think there's a whole context there, doesn't it? And I think for me it's really important that it tease out where there might be that kind of broader social and familial or socioeconomic issues, and we're not overly medicalising things that are not fundamentally that kind of problem. And I imagine that your project is assisting with that. Is that okay?
Yes, very much so. I think it's really important that it's about getting as many families through the doors of family hubs. By offering all the activities in one place, it widens the reach. So we've seen a huge increase in footfall through doors and those sorts of things. And often for children, for families where they've got a child where they think there might be something wrong, sometimes it's a challenge to come through a door because they don't want their child to not behave like other children or one thing and another. And if you're not careful, they're the ones we miss that could equally, struggle with income and those sorts of things. So yeah, it just widens our reach, really.
One just quick thing I'd like to add to that, if that's okay, is through a lot of the pathway development work that I've been doing in recent months, I've been trying to look for kind of the holy grail of the one pathway that we need to use all of the time. And actually what I'm finding is we don't just need, this is a great pathway, but one pathway doesn't work for everybody. And actually by finding a pathway that can suit the majority of people that we can filter through, then it actually frees up our time to be able to adapt for the ones who need something a little bit different. Yeah. So, for example, one of the benefits we found as professionals is this integrated working has been amazing. So I've kind of said, I've got a family we've seen and there's this issue about access and what can we do? And then the Family of Hub staff have said, we'll go out and see them in the home, we'll do a bit of work with them then, we'll bring them into this. And that's not the same pathway for everybody, but because we've got those relationships and we've developed this trust and joint working, we're able to say, I'll do that for you, you do that for me. We've kind of worked it out so then it's the best fit for the families.
Excellent, brilliant, thank you. Well, thanks for bringing that work here. Honestly, Chris, I just said no more comments, but because it's you, how can I refuse you? But the last one then.
Only because you're really kind. Thank you, very laudable project, thank you very much. A question about understanding how it got here. So just trying to connect it to our Start Well priority, school readiness, and just the link. I mean, yeah, in its own right, very, very laudable, and a lot of learning about how we support people who are waiting generally, and there's a lot of learning from it. But just talk through the link, school readiness to here and the priorities. I don't think we've had that back for a while on what our key priority is. Thank you.
Yeah, no, that's fine. I can pick that up. So, as you know, we've focused Start Well around the school readiness priority, and as we drill through the areas where we're outliers, we come to the special educational needs indicator, and within that, speech and language speech and language communication needs is one of the biggest areas, and so this project really ties in with that, alongside the neurodiversity special educational need factor as well, and so it's a really close link in. I am working with Michelle and Andy Smith around the wider plans and further work that we want to do to come together as Start Well as a whole. So this is just one element of something much bigger as we progress those plans. Thank you.
Thank you, and I mean, just to cap that off then, thanks, that's really an excellent report. It's really encouraging work. I mean, you do acknowledge that, you know, you're working on limited numbers at the moment, although impressive numbers, but you'd like to be expanded, and that resource is an issue, and we know that through all the comments, and that resource is a real issue, so we do acknowledge what you've been able to do and the importance of it, nevertheless. Thank you. So now I'm going to move on quickly to the update on the Stay Well key area of focus, and Jane Needham is going to give us that.
Hi there, right, yes, I'll give a quick update on the key areas that I want to draw out, and then we've got a short presentation that will illuminate all the information that's in the paper. So the two areas that I really wanted to focus on for this particular paper was around the pre-sprint work, and to bring everyone up to speed on where we're heading with that next, and then to sort of continue to escalate for support from the ICP around the issues we've got around the lack of data sharing, which impacts this programme, but I suspect will be impacting other programme areas as well, just to see if we can progress that further. The other thing that I just wanted to have as a running theme through the work that we're doing is that, as much as driving forward on the Stay Well key area focus, what we were very keen to identify through this work is to test integration. And as we talk through the work, as I talk through the work that we've been doing, I hope that you'll pick up around the benefits of the integrated way in which we're working. And certainly from the point of view of national attention, it's drawn attention from the NHS Confed, who've asked us to be involved in some national work around driving forward on obesity, but particularly with regard to an integrated focus, so positive in that respect. So if I just cover on to the presentation, Lindsay, that's great, if you wouldn't mind going to the next slide. So what we've got here is, so for people who will have been familiar with the work that we did on the smoking cessation approach, which we did last year, we adopted a sprint approach. We took learning from the sprint approach, and what we have tried to do is to embed this learning that we took from the smoking cessation into how we've delivered against the obesity. So the key pieces of learning that we took forward were that you absolutely needed to have a data collection pre-sprint phase, and you needed to really reinforce that you've got that exit route out of a sprint phase, so that the work that you've managed to progress in that focused piece of time with through multi-agent and multidisciplinary working, you've got somewhere that it will land into and has a commitment to drive it forward. So we've had the pre-sprint phase, which went from October through to January, and what the pre-sprint phase was looking at was the current state in terms of what we have for weight management services, the differences and the variation, which I'll come on to in more detail around the service offer, to consider the future state, so looking at a population health management approach, to consider if this is what it's like now, what can we expect in the future, to do evidence reviews of what the evidence base says is the most effective way of delivering weight management services in a system, so that we know we can compare ourselves against what the guidance is telling us and what the evidence is showing us. And then to horizon scan for innovation, to see what new developments there are with regard to tech, pharma, and then again this population health management approach. And that's That last bit is where the NHS Confed have really approached us to say, can we get on board with that? So the pre-sprint phase is finished, and just around 2 weeks ago, 2 weeks ago yesterday, we had a timeout session, 4-hour dedicated session in partnership with partners right across the system. And I want to thank everyone here who either represented or allowed representation from their different parts of the system, because we had about 60 people in a room, ranging from general practice, Health Watch, voluntary community sector, right the way through to all the providers, Nexus, our business information contact, and also the ICB, so really, really well attended. And we presented all the pre-sprint data, and the slides will talk through what that pre-sprint data we've managed to find out, and we've set a direction then for the establishment of some work streams to drive forward a sprint approach, which, as it says up on there, will go from February through to May. And that will be a 12 to 16 week period of time where those partners, working in an integrated way, will drive forward on key actions that we feel are deliverable within that time frame and which are essential to be completed in order that at the end of the sprint phase we can drop and hand over the work that we've done into the Joined Up Care Derbyshire Obesity Alliance and then the Integrated Place Exec. So next slide, thanks, Lindsay. So the scope of the sprint, just to make everyone sort of bring it up to speed, so people will be aware that there are 4 tiers if we look at it in a pathway approach for obesity. Tier 1 is classed more as a health promotion, public health approach. We agreed, working with local authority partners, that this sprint would focus on tiers 2 through to tier 4. So what we've got up here is a quick explanation of those different tiers, and I know that there's a diagram in the paper. So tier 2 is what you would think of as the non-specialist community-based weight management services. They're delivered within our county and city footprint by the 2 local authorities, so Live Well for the city, Live Life Better Derbyshire for the county. And there are also some national digital offers which complement the tier 2. So you've got the 12-week digital weight management programme, which is NHSE commissioned, and you've got the pre-diabetes digital programme, again, which is NHSE commissioned. We've then got tier 3, which is the multidisciplinary, it's what we would call a specialist weight management service. So it's where people with particular needs around severe obesity and complexity, generally rooted in psychological and mental health, the impact of that upon people's perceptions of weight. And that uses behavioural interventions, and NICE have approved for the inclusion of injectables, so pharmacotherapy, within tier 3. In Derbyshire, we don't have a position at the moment on the inclusion of pharmacotherapy within tier 3. It's being carried at risk by one of the providers who delivers in that area. So the 2 providers are More Life, who cover the Glossop patch, and Derbyshire Community Health Services, who cover the county patch. There is one national programme that's a digital offer that aligns to this, which is the Diabetes Shakes programme that people might have heard of. So what you can begin to see is at tier 2 you've got a local offer and then a national offer, and at tier 3 you've got a local offer and a national offer. There is also much more news media coverage of online companies that are beginning to offer the tier 3 injectables into that part of a weight management pathway. At the moment in Derbyshire, we are not entering into those arrangements. Then tier 4 is bariatric surgery to induce weight loss. So that is delivered by UHDB in our area, and UHDB deliver that service for not only Derbyshire but 2 other geographical areas. And as it just touches upon at the bottom, is that we excluded tier 1 because that's sort of like that health promotion, a whole population approach, and what we wanted to do was to focus on the healthcare provision for weight management. Thanks, Lindsay. So I think the next slide, what we've tried to do here, these are a couple of slides that were picked out of the pre-sprint work that we did. What we tried to do was to give people a visualisation of the impacts of obesity and overweight within the population of Derbyshire. So the scale of the challenge currently is that there's around 405,000 people in Derbyshire who are modelled to have a BMI of 25 plus. If you are of an Asian ethnicity, then actually your at-risk factors for obesity and overweight kick in at someone with a BMI of 23. But what we've done here is focused on the core, what people would recognise through the BMI data searches around a BMI of 25 plus. And if you just looked at, so of the proportion of Derbyshire, how many people does that equate to? It equates to everyone in High Peak, everyone in Derby City and everyone in South Derbyshire. And it's around and about 37.5% of our population. What I'll go on to talk about is that in terms of the commissioned capacity of services within Derbyshire, both local authority and NHS services, they have the capacity to deal with 1% of what we have modelled there is people with a BMI above 25 plus. Thanks.
Sorry, Jane, just for clarification, did you say 1%?
1%.
1%. Right, okay, that's shocking. So 1%.
So then what we did was we looked at, so thinking about affordability, because picking up on the point you've just made there, Councillor, is that we need to consider affordability against an evidence base. And what we would look to do is to make sure that we've got an evidence-based weight management pathway that is targeted towards those people who need it most, not restricted through an issue of affordability at a population level. So if we look at the at-risk groups, we can see, I'm not telling anybody anything that they wouldn't know already, is that obesity and issues of obesity and overweight are concentrated within certain demographic factors. And so if we look at our areas of deprivation, we can see that there's high prevalence of obesity and overweight. If we look at, it says older age groups there, I want to just clarify that. The data that we got actually demonstrates that it's age 35 through to 74 that you are more likely to be overweight or obese. Now that is particularly important in terms of two areas. The first is we know that people who have who are BMI of 25 plus have twice the healthcare utilisation of people with a below 25 BMI. What we also know is that the people who are more likely to have obesity or be overweight are in that 35 to 74 year bracket. So there is a worklessness issue that is attached to this too. So in terms of benefits realisation, there is two potentials. One is an economic benefit of ensuring that people are supported to return to work, and the other is around the healthcare utilisation of people with a BMI of 25 or above. The other, we can go on to talk about black and minority ethnic. White British have a statistically significantly higher prevalence of a BMI above 25. Unemployed and economically inactive, which plays to that point I was just talking about in terms of the time with the age. Educated to level 3 or below, and then people with who have a mental health diagnosis. And the more severely obese, the closer the association is between mental ill health and obesity. We've got a reference there to children from families where at least one parent is living with obesity. What we do have is a more well-established children's obesity work going on in the system. This programme is focused on adults which hadn't got any dedicated resource being given to it, which is why the Staywell group chose to focus on adults' obesity. The other thing that I just think is interesting that we pulled out is that weight stigma is a recognised barrier to accessing healthcare, both from the perspective of the individual, but importantly from the perspective of the person they interact with. So weight stigma is an inequality that is occurring in our system without us openly talking about it. So a perception of a clinician who is engaging with someone who is overweight or obese, there is a recognised stigma that happens that determines the type of conversation and the service offers that are made available to that person. Thanks. So what the data tells us, so what I've just done there is talked about our current state. So think 405,000 people modelled, 1% capacity across our services. And when we look at the totality of the Joined Up Care Derbyshire budget, so if we look at the local authority and the NHS spend, it's modelled at 0.08% of our budget is being currently spent on healthcare services for weight management. So the population and obesity projections, it's on track to grow. Rising obesity will disproportionately affect disadvantaged groups and therefore worsen, it can be reasonably anticipated, will worsen health inequalities. Increased obesity is linked to higher multimorbidity rates, so there will be overlapping care needs. And one of the things that we have pulled out is if we look at the service offers for weight management and for diabetes, there is a lot of crossover. So therefore, is there an efficiency gain we could consider from what is the support that we're giving to people with a diabetes diagnosis and a weight management? Are we dealing with them as two separate issues? How can we bring that together? So the main messages from there is a younger population who will be becoming more obese, who will be being affected with more comorbidities and therefore require greater healthcare utilisation if we don't start to stem some of this through preventative intervention. I'm just thinking, is there anything else? Yeah, BMI records. Oh yes, so the very bottom point is an interesting one to pull out. So what the pre-sprint data has demonstrated to us is that you are more likely to have BMI recorded in your GP record if you've got a long-term condition or you are of an age where you are entitled to a health check. So if you've got a long-term condition, you're being pulled into general practice, generally speaking, for regular checkups, and monitoring of BMI is therefore in the GP record. For the rest of the population, if you've not got a long-term condition, the first opportunity is if you called in for a health check for it to be in your record. So there is a time lag for people who don't have a comorbidity, who don't have a long-term condition, to be missed as a BMI recording until and if they present for a health check, at which point it would be logged there. So we've got quite a gap in our understanding of who's got an elevated BMI because of that particular nuance. And that will be the same across the country. It's just that our pre-sprint has pulled out that point. Thanks. So the overview of the Commission pathway, I've talked a little bit around this already, so I won't go into too much detail, but you've got Tier 2, Live Well and Live Life Better, Derbyshire, in the 2 local authorities, and they have got a capacity between them of about 3,100. Tier 3 is DCHS and is More Life in Glossop, and they've got a capacity of about 625, and Tier 4 bariatric surgery. The latest information that we can get, which we've pulled from NHS, what's called SUS data, is that we're doing about 108 operations a year. So that begins to tell you about the number of people who are benefiting from our services compared to who may benefit. And it's not to say that every one of those 405,000 people should receive support, but there's something between 1% and 405,000 that I probably think is worth consideration. There are the National Office for Joined Up Care Derbyshire residents, and what we do know is that we are underutilising the NHS Digital Weight Management Service. We are a high performer against referral into the Type 2 Diabetes Pathway to Remission, so that's the SHAKES programme I was talking about, and the NHS Diabetes Prevention. So we're doing well on the diabetes prevention and less well on referrals through to the digital weight management, which is an opportunity to increase access for people who might benefit from services. Thanks, Lindsay. So this is a really quick summary through. So what would be the main points I would want to pull out here without going line by line? The main points I would want to pull out is that our pre-sprint is showing we've got services for 1% of the population and we're spending 0.08% of our budget. It also shows that the services, there is disparity between access criteria, the service offer, the type of delivery, and the outcome measures that are being monitored, which means we have no ability currently to assess which are the sweet spots and which ones are delivering well and where there is area for improvement. And it is fair to say that the service models have grown from historical services that are in place and are unfortunately in a position where through affordability the models have been tailored to meet affordability rather than to ensure that we are delivering the best that we can for our population. So there is variation in our services, and there are certain sort of local gaps where we know that bariatric surgery in the Glossop area, the provider of bariatric surgery in Glossop is serving notice. So there are lots of little nuances that I wouldn't go into the detail about here, but this is a ripe opportunity to make sure we can improve this pathway. Thank you. So there is, what we are aware of is within our service offers currently, we are probably not maximising the digital programmes and tools that are available. So there is evidence around the delivery of weight management programmes which show that when someone is offered, so this is from the national programmes, when someone is offered a digital resource and someone is offered a face-to-face resource, they choose the digital resource. So I think our view in the pre-sprint is this challenges some of our thinking around patients prefer to be seen face-to-face, prefer to be seen one-to-one, clinicians prefer to see people face-to-face, prefer to see people one-to-one or in groups. It challenges some of that thinking. It shows that where people are given the choice, 70 to 80% have chosen to go to digital. What we need to do, and we can't do, is compare what are the outcomes of people choosing digital compared to the outcomes of what is predominantly face-to-face or one-to-one Teams offers within Derbyshire, because the outcome measures are all different across each of the services. So the advantages to the digitalisation is the scalability, the flexibility, cost effectiveness, and there is a leading evidence base on this now, and that will be part of the NHS Confed work that we would want to be brought in. We do need to consider digital exclusion, so I want to make everyone aware that that's not something that's passed us by. And I think I shouldn't have many more to go through, Lindsay. So, So the weight loss medications. So everyone will be aware of the weight loss medications that have been much muted in the press. So currently there is one that is, there are two that are approved currently, and a third one which has recently been approved. So the weight loss medications are a fast evolving, rapidly changing position. So semaglutide is currently available through a very, very limited mechanism within one of our service providers for Tier 3 and is being delivered at risk by that service provider. We haven't got a fixed position on that within Joined Up Care Derbyshire. More pressing is that tirzepatide, which is the newer drug that is mentioned there, was approved by NICE just before Christmas, and the system needs to have a response to that by the end of March for Tier 3 services and into general practice in June, because that's when the NICE guidance will kick in to say these drugs need to be made available. Those are very live discussions in the planning round, and the NICE guidance, because of the impact on NHS budgets of the rollout of these injectables, there's a 12-year trajectory to get these injectables into everyone who the NICE guidance says will benefit from them being able to access them. So to just show you the scale of opportunity and the very tentative approach that NHS England is taking around that. So it's rapidly changing. We know that we need to get this resolved. It's a pressing issue with regard to Joined Up Care Derbyshire at the moment. Thanks. So new NICE guidance. So this was really interesting. We were doing a huge evidence base, evidence review of what is the evidence around Tier 2, Tier 3, Tier 4, how does it compare against what service offers we've got, and 2 days before we were due to do the time out, new NICE guidance dropped around weight loss and weight management services, which collapses quite a significant number of existing NICE guidances into one document. And it talks about a weight management pathway that is designed around the one individual patient, as opposed to you meet this criteria, therefore you go into this service, or you meet this criteria, therefore you go into that. It's talking about holistic care wrapped around one individual patient and their needs. So this is forming a huge part of our sprint work to understand if we were to really redefine and be brave around our current service offers, what might that mean in terms of how we can increase our accessibility and our outcomes for patients through weight management by adhering to the new NICE guidance. But at best it's 2 weeks old now, so I'm not in position to go into any more great depth around it, other to say it's very, very pertinent timing for us. Thank you. And then the next step, so we've finished the pre-sprint phase, we've done the time-out session. It's a rapidly evolving landscape, both in terms of the injectables and in terms of the NICE guidance. We know that we've got a myriad of pathways, both locally and nationally, and there is opportunity to improve what we've got, even within the funding that is there. There is also a significant question for the ICP to consider around our embracing of obesity, and to start seeing it as, to frame it as, this is an investment to save. This is around what we can save if we do this properly. This is not about how much these people cost us. So I think that there was just a real willingness to try to change the narrative around how we approach this now. And that should be it, I think, Lindsay. Thank you very much. So that's the presentation. The other thing I just did want to come back to is just around the...
just briefly, if you may, Jane,
yeah, that block, the sort of the real issue around the data sharing. It was just from the start of the presentation.
Thank you, Jane. I mean, that is, you know, a tour de force, really. I mean, there's so much in there, so incredibly important, and so much to look at, an impressive amount of work so far, and so much to go on to try and address in a scenario with very, very tight budgets. So the recommendations are 2 points. One, to note the data sharing problems and to find support resolution to those. And two, to note this report and its outcome. So just very quickly, I'm going to cut straight in because in fact, I'm going to stop myself saying anything on the content of this because obesity is an absolute key focus for me as a cabinet member in Derby. So I could talk forever, and also particularly around childhood obesity in Derby, but I'm not going to do that because that would be inappropriate. I am going to, though, to take the first point, if I may, because with respect to 1.2, bullet point 2, I was recently at the National Adults and Children's Conference, and I was got at by people on a stall who have a platform which is offering exactly what you say there. And I know these things cost money, and I know data sharing is complicated and sensitive and not a given. But I did ask our new Director of Adult Social Care, Andy Appleyard, to talk to this company, to talk about what they've got, what it is they're offering and whether it's credible. So if people don't mind, I'm just going to ask Andy, put him on the spot and say, have you any thoughts on that, Andy? I know you've been talking to them a couple of times.
Thank you. So, hi everybody, Andy Appleyard, Director of Adult Social Care Services at Derby City Council. So, as Alison's talked about, as the Council has talked about, we've met with an organisation called Sentinel Partners, who, like USP, is how they can draw information together from across any health system, how they can then present that data back to you, so you have some advanced information about what needs can look like and the sort of pressures that you will have at your front door. It's still quite early stages in our conversations at the moment. We think that the biggest hurdle that we will have will be the IG, of how do you get everything together, but I'm more than happy, Jane, to have a conversation with you outside the meeting. As I say, very early stages of those at the moment. They have said, as a bit of a proof of concept, they might be able to do something free of charge for us about some of our safeguarding pressures and bounce back in terms of safeguarding. So, as I say, very early stages, but very happy to have as many people involved in those discussions as possible. Thank you.
It sounded to me like the answer to everybody's problem. I was just thinking, oh gosh, how much are they going to charge us for this? But then they were so keen to do it to us for free as an ICP, just to get somebody to take on their product. But anyway, so I left that in the good hands of Andy, who could judge. Jim.
Thanks, Chair. Chair, my name's Jim Austin. I'm the Chief Executive at DCHS. Just to reinforce what Andy said, I'm sure Sentinel are a very good company. We have platforms that can do this now. It's not the technology that's the problem, it's the data sharing agreements, the IG, information governance that Andy mentioned, that we have a pressing need for us as organisations to share data effectively. There are structures and ways of doing that. It will require general practices, 110 of them, and foundation trusts and local authorities to do that. I don't think it's a technical problem. This is around getting the right people in the room to understand the responsibilities we have as data controllers and then agreeing about how we're going to share that. And that needs to be with the consent and information of the general public so they know how their data is being used. It's a really knotty issue.
Well, thank you, Joe. I mean, I do want to come back to the obesity, Jane, because it's so critical. It's my real interest, and I'm sure it's so important. But just on this issue, then, because we did have, not long after I'd become chair, we had some initial stab, didn't we, at some reports on potential data sharing projects, and I have to confess that I do not know where we're at with any of that. Can anybody, Chris?
So, Chair, I think it was at the start of your chairing of this meeting. It was the Section 251 agreements, I think, we were talking about. So there was some initial investigation about whether we could implement a Section 251. It is a long, drawn-out process, and actually the initial templates we were offered from another area to base our Section 251 on would not have been sufficient to move us to a safe legal position. We're in that position at the moment where we need to continue to work with individual parts of our system to get the right data sharing agreements in place to allow data to be shared between different organisations. We have signed up to the National Federated Data Platform, which is one of these platforms which allows us to bring data together from across multiple organisations and to use it in a single, as a single source of data by everybody. That is currently being populated particularly with acute trust data. It will take a period of time then to add in things like general practice data, and then we'll need to look into building in data from, say, social care settings, voluntary settings. That can be supported by Section 251. Week before last, I received a steer about 2 areas in the UK which actually have high quality Section 251s that we could use as a potential template. And we could base our plans on that, on one of those going forward. But even then, it's probably at least an 18-month process to take us through to achieving a full Section 251.
So whilst we're some way from that ideal scenario of sharing, from the point of view of the system, of course, obviously members of the public need a lot of assurance and safeguards, but what you're saying is there's work in progress on this, even albeit slower than you'd like it to be.
Yes, Chair, there is work in progress. It is deeply frustrating, I'm sure, for everybody in this room and many of our colleagues outside of this room about the pace of progress, but there is slow progress in this space.
Thank you. Well, there is progress, so we can say that. That's reasonably positive at one level. Thank you, Chris. Sorry, any comments and any other further comments? Robin.
Thank you. So I just wanted to ensure that everyone was clear about the decision not to include the Tier 1 part of the obesity approach within this piece of work. So Tier 1 is very much around the environment that we live in and the wider determinants that impact on obesity. And I just wanted to make sure everybody understood that we don't think that's not important. What we feel is that there's already a significant amount of work ongoing through the Children's Healthy Weight Strategy work that impacts on everybody, because that's very much around the whole systems approach to obesity. So we felt that there was already work ongoing in that area, and what we needed to pick up through the sprint was the gaps which relate to the pathways for adults. So that was the first thing I wanted to say. The second thing was just to really, really welcome this work. We've had a gap around adults for some time from an obesity perspective, and we know that after smoking, obesity is one of our biggest drivers of ill health, and particularly diabetes, CVD, and cancer, and especially breast cancer as well. So a really important opportunity, as Jane was mentioning, to think not about the costs of any additional investment that might be needed, but actually what this work might do in releasing costs into the future, because there's a real opportunity, as was mentioned, to invest to save by investing in this pathway and making it robust.
Yeah, absolutely. Not to mention the impact on the quality of life of people affected. Yeah. Do you have any other comments or queries on this? No? Well, I think I'd like to thank you, Jane. I can't stress enough how important this area of work is, in my opinion. And I think, we've touched on the area of the issue of data sharing and the digital platform. And I think people have noted this work, and so we're all happy to accept the recommendations, are we? Yes. So, did you want to say anything else quickly, Jane, before we move on? No. Right. Thank you very much. Yes. So thank you. So now I'm going to move on to Kirsty McMillan, who is here. Thank you, Kirsty. Who's going to talk to us about the integration between Derbyshire Community Health NHS Trust and Derbyshire County Council. Thank you, Kirsty.
Okay, it's on. Afternoon, everybody. I'm Kirsty McMillan, Director of Integration, as Chair's just introduced me. And I should say I'm here on behalf of obviously the Trust and also Derbyshire County Council. My two colleagues up there can't make it today, but we've got Simon here in any case. Yes, so what this presentation is about is some proposals that are being worked up between the two organisations, and the reason that there's only a few slides that they're here today really is partly for information giving, but also to see how the ICP would like to be updated in the future should these proposals go forward. So I'll just quickly run through the slides. I don't know who's driving them. Is that Lindsay? Yeah. So this is not necessarily new in that the local authority and the Trust have been working together for a number of years anyway. The sorts of services that are on the slides are typically the sorts of services where health and social care interface anyway. But in recent years, this has really sort of ramped up, particularly with the development of Team Up. So we actually have some teams that are already co-located. Obviously, in relation to hospital discharge and managing urgent demand from the community, that's an area where there's a long-standing history. But more and more, really, and we've talked about information sharing, a lot of what both health and social care organisations are doing is jointly working together to try and meet the needs of local people. So if we move the slides on, partly the reason that Derbyshire County Council and the Trust are considering forming a more formal relationship is that we're actually all facing similar challenges, which I'm sure this partnership board has considered previously in relation to other services. But essentially, we've got a scenario where we've got rising demand and we're not always able to meet that, which obviously leads to waiting lists and people being sort of stuck in the system longer than either of us would like. Similarly, we do have separate capacity to meet the demand from the population, but actually we're probably not making the most of it while ever it remains separate. And so we have pockets around the county where some services to do with their legacy pattern are more established, but there are other areas where people are having to wait slightly longer. And whatever we've got separate teams, and again, this is no different to any partnership really, where there's lots of different agencies and organisations trying to work together, but you do end up with duplication of effort. There's lots of transfer points and handoffs between organisations, and all of these add in delays that end up really detracting from the experience that an individual goes through as they try and move between organisations. And similarly, the fact that we remain as separate organisations with separate cultures, to a degree is helpful because we can look to try and play to both strengths. But actually, when you're facing similar challenges, the more that you can do things together. I think this is all about gains, really, in terms of trying to make the most of the available resources that we've got. So the next slide just describes where we're at so far. So the County Council's previously, in fact, most of last year, been consulting on a variety of services that it has jurisdiction for. And certainly in relation to the social care services, the Cabinet has made some decisions about where those services will focus. And this is in relation to services that the County Council are responsible for in terms of their own provision. So where they are providers of services, the County Council wants to focus on long-term care with a particular emphasis around carers and those individuals living with dementia. But they've also confirmed their commitment to continue with the short-term reablement services. And those are the ones that very much are at the interface between health and social care, often known as intermediate care. It changes its name throughout the years. But the County Council has certainly, from a strategic perspective, been quite clear about where it sees the support that it needs to be making available. However, in November, both the Council and earlier in December, DCHS felt they did want to explore whether bringing some of the services together in a more formal way would actually be helpful in terms of trying to manage that inconsistent and unwarranted variation, really. So consultation has been taking place. It just closed about 10 days ago. And the consultation was quite clear that it was about trying to explore the opportunities that the Health Act provides in terms of bringing services and functions together. And the ICP may well remember, I think I came to this meeting probably about 12, 18 months ago to report that DCHS at the time and Derby City Council were already, at the time I believe I came, considering this. And since then, they have actually gone forward and created a formal partnership, which some people will be pretty familiar with, I'm sure. So just moving on, and there's a slide at the end which talks in detail a little bit more about the legislation around this. I'm not going to dwell on this too much, but certainly the NHS Act that this forms under would allow the pooling of budgets, the pooling of services, and it's effectively allowing flexibility between NHS bodies and local authorities in delivering their health-related activities. So this is not unusual. For example, the Better Care Fund is a pooled budget under the same legislation. But certainly that's the piece of law that enables organisations to consider integration in a more formal sense. And in terms of the stages, like I've said, we've been out to consultation, and at this stage, neither the County Council's Cabinet nor the Trust Board have formally considered that consultation, but that is going to be happening this month. So in the next couple of weeks, both of those organisations, in terms of governance, will be reading the feedback from the consultation. So depending on the decisions that both parties come to, if they do want to consider this in more detail, then working through a variety of matters mean that this is not really a quick fix. So it's likely to take around about a year or slightly longer just to make sure everything is properly considered. And the sorts of things that the organisations will consider will be being clear about which services does it make sense to include, what are the resources available, specifically what would be the benefits of the partnership in terms of operational improvements. And then all of that would need to be set out in a formal agreement, setting out really how we can continue to monitor that these objectives are being met, which is the point of using the Health Act flexibilities. And it may include, but that's still to be worked through, whether it's right to have all of the teams under a single structure. Not all partnership agreements do that, but in some instances they do. So that would be what would be going forward if the Cabinet and the Trust Board agree to explore this further, and we'll know about that in the next couple of weeks. And then I think that is probably it, other than wanting just to double check everyone, or particularly this partnership, was clear about the sorts of opportunities. I think this is relevant given the nature of the ICP. This is about making a long-term partnership, and DCHS and Adult Care in the County Council are pretty, doing pretty well in terms of managing services. They're both, from a regulatory perspective, good providers. And actually, this is really about using the opportunity to scale up services that are already in existence to try and meet demand as best as possible, which I was mentioning earlier. One of the benefits in particular for the County Council, but arguably also for NHS commissioners, is the more effective we can be at keeping people independent at home, making sure that after an acute episode, their skills as far as possible are regained, is that the ongoing cost and therefore demand for support and care should be reduced. The more effective you are at dealing with people in a kind of re-abling sense, then there's definitely evidence that that will reduce the ongoing burden, if you like. It can't prevent deterioration completely, but it certainly will help manage that demand and spread resources as far as possible. Similarly, in relation to repeat hospital admissions or just repeat admissions really into services, the more effective we can be together by stabilising an individual's sort of home and support circumstances, then we definitely are expecting to see less people sort of bouncing around services if we can kind of join up our care delivery. And ideally, I've mentioned Team Up before, bringing services together and trying to kind of cut through all the barriers. We've talked about information governance already, since I've been here anyway. If we can do this on a scale between a couple of organisations, it potentially is the blueprint to broaden that out. So I know that certainly the Trust and Derby City Council are learning as much as they can from the partnership they've struck within the city and seeing how scalable that can be in relation to other activities. So that's probably all I was going to mention as far as where we're at for now. But bringing back to the cover report, it's just really obviously open to any questions. But if the partnership could think through how it would like to be kept informed if it does in the future.
Okay, thank you. And that's what we're asked to do. The recommendation is to consider the report and to see whether and how we do want to receive any updates. Just going to ask, as this concerns Derbyshire County Council, I'll just ask Carol first of all if she wants to come in at all.
I had a feeling you might say that. It's not actually my portfolio, but unfortunately, Councillor Natalie Hoy portfolio, and she's been working very hard on it. And in fact, Simon was in the Cabinet, and he may want to speak. We had a Cabinet CMT meeting this morning discussing this. And, looking at what we're doing, we're all struggling with budgets and we still want to deliver the best service we can. And it just makes sense that where we've been doing things there and DCHS doing something, is there a way we can come together to deliver, and it will save us money in the long run. And I think there's been a lot of work. We've got a 75 agreement in public health, which works really well, gives you flexibility. I can't preempt the decision of Cabinet next week, but the report's got to Cabinet, so I have a feeling it's certainly going one way. But I just think it's a very positive, but it's getting the message to me. I mean, you might agree, Simon, it's getting the message across to some of the people that might be affected because of what we will have to do. It's reassuring them that they're still going to get the best service they can. There's sort of, you've always got the scaremongering that, this is going to cause problems here, there and everywhere. I think it's just we need to make sure that we get the message across that it will deliver, better in the long run. But Simon would probably like to come in on that.
Thanks, Carol. Simon.
Turn on? Oh, I can now. Yeah, thanks, Chair. Thanks, Carol. So, yeah, just to reiterate, absolutely, this isn't necessarily anything new. This is building on what is a really good and strong partnership arrangements already with Derbyshire County Council and DCHS. So the areas of activity that we're looking at are areas that we jointly operate and deliver in now. It's really just about strengthening and formalising those relationships and those partnerships so that we can come together, pool resources, both financial and people resources, to get best effect for the people of Derbyshire, if you like. So, in every conversation we hear, and in pretty much, I think, all of the conversations we've heard in this meeting today, there's issues around capacity, issues around resource, whether that's people or money, to be able to deliver services to meet what is a growing demand across the piece in Derbyshire. And this just gives us a chance to make best use of the collective resources that we've got in a coordinated and informed way. Not at all being built on the basis of making financial savings by coming together. It is about driving efficiency. So, and just to note, I think the Trust Board meets tomorrow, and Carol's already referenced, but the County Council Cabinet meets on the 20th. So it will be beyond the 20th, where we've got clarity on both organisations and their agreement or not to continue to develop the proposals. Thanks, Chair.
Thank you, Simon. Yes, and of course we've already followed this path and completed it. It's all actually operating in Derby already, isn't it, Kirsty? Jim?
Thanks, Chair. So I was going to come back to the exam question. How would this group like to be informed on progress? I wonder if I might suggest, I think it would be useful for this group to see the success and benefit of the DCHS and Derby City Council Section 75, this kind of agreement, in maybe 6 months' time. It's quite early days at the moment. We are definitely seeing a capacity improvement, so a sustained cost, but a capacity improvement coming through. That could report back here. That will then give time for the pre-work that's going to go on with County Council should both organisations agree to go ahead. So I think there's something around 6 months to come back here with the Derby City piece, and then maybe 6 months after that we can then get into a momentum around the rest of it.
Okay, thank you, Jim. That sounds like a good suggestion to me. We do actually have an action log, don't we, Alison? Yes, in development or operating as soon as this meeting is finished. So we'll add that to the action log. Thank you, Jim. Thanks. Kim?
Thank you, Chair. Yeah, I mean, it seems eminently sensible to me in terms of Pauline, and actually I think I was at a place meeting that Kirsty came along with some time ago. So for me, really glad it's progressing. I think what I would like to suggest is actually, I still say that the voluntary and community sector is a huge part of the solution in terms of this space, and I'm really keen that moving forward that the sector is involved in sort of the development and the planning of this, because fundamentally, if you're based at community level with very granular services, that's going to be more of cost effective. It's going to prevent escalation and again offer cost savings. And I think if we can empower communities to be supporting communities, then that's a bit of a win-win. And at the moment, I'm not sure where we are in that space.
Okay, thank you, Kim. Kirsty.
Yeah, I think it's a good offer, Kim, that we'll definitely take you up on. I mean, I'm obviously very passionate about this, as everybody knows, but one of the main reasons is I think local authorities have got a lot in terms of what they can offer the NHS in tapping into much more of that grassroots community level activity, primarily because local authorities have had to really connect in a range of ways with local people. Not to say the NHS doesn't, but the breadth of services that local authorities have to deal with means that they're much more in contact with people in a wide range of their lives. And of course, a huge component of that is the voluntary and community sector. So, I mean, it's not as explicit as it could be, but that is certainly one of the benefits of bringing social care closer to the NHS, because they will then also bring through a more of an understanding around the role of the voluntary and community sector. But we'll probably just take some time to think about the right time to bring the VCSE in terms of shaping the objectives of the partnership, Kim.
Thanks, Kirsty. Yes, and I agree with that. So I think I'm inclined to say, because of timing, that this is the last comment on this paper, if that's okay. So it is going to be Chris again with the final word.
Kind again. I mean, on the surface, I think colleagues are broadly supportive. I think significant benefits envisaged from it, and Jim's right, we need to understand the learning from the city. It's a nuanced comment around unintended consequences, so we need to be mindful to the risks around unintended influence on the Better Care Fund, because this is about pooling budgets post-decision, so we need to keep an integrity of Better Care Fund decision-making between the commissioners, ourselves and particularly County Council in this regard, so we just need to be mindful of that. We haven't come across an issue with regards to the city there, but we just keep our minds open. And then onward unintended consequences. So if we think in the fullness of time, if this might lead to transfers of staff, then we need to have a view of that and make sure we didn't have unintended consequences on either party. So supportive in general, Chair, but thank you.
Thank you, and I'm sure that unless there's a compelling reason to respond to that now, no, I'm sure that will be taken on board. Thank you, Chris. And thank you for coming, Kirsty, and presenting that to us. And thank you, Jim, for sponsoring that report. We look forward to seeing where that goes. Okay, now we're going to move on to the report. Remember we had the development session. Seems like quite a long time ago now. Nick, there's a report has been written in response to that. And Nikki Doherty and Robin Dewis are going to speak to that report. Thank you.
Thank you. So hopefully for those of you who were there, you'll recognise the content of the paper. And I'll just kind of summarise for you what we're setting out. So you'll recall that we had a broad discussion around a number of areas, and that we summarised into that there were a number of positive areas we were really pleased about, one of them being the voluntary and community sector actually. And then some areas of opportunity for development, which broadly fell under delivery, governance, assurance, and alignment. And by alignment, we meant to strategic planning, decision-making, and use of our resources, so joint commissioning, essentially. There's a table 1 on page 45 of your pack that sets out the proposals underneath each of those areas. And within that, we're asking, within this paper and discussion, we're asking you to consider and support those. There are, for 3 of the actions, 2, 13 and 15, some proposals about how we might address those. So they're in Appendix 3, 4 and 5, and Robin is about to talk us through how they would work. And then I'd also note, just in relation to the section on enhanced delivery, that the Joined Up Care Derbyshire Executive is currently reviewing its terms of reference, and that's quite aligned to the proposals that we've put forward in this. So there's an element of conversations overlapping in that space. We've then talked about what the next steps might be. So we're suggesting that we should consider the impact of the Integrated Care Partnership since its establishment and what progress it has made. In particular about progress against our integrated care strategy and some of the things we've been talking to today. And I know when we've spoken previously, coming in new to the system, I can see a lot of substance in what happens in our places and our partnerships and our integrated care working that I haven't seen in other areas. But we don't describe it well. So I think that's an important piece of work we need to do together. And secondly, we need to review and, if necessary, refresh our integrated care strategy, which goes between 2023 and 2028. And then, so the recommendations are to note the overview that we've provided, consider and discuss the proposals set out in 4.4 to 4.7 of the report, agree to the next steps that we've proposed, and consider the proposed agenda framework and principles and guidance for authors, which Robin will now take us through.
Thanks, Nikki. So we have Appendix 3, which is the draft agenda forward plan. But I'm not going to dwell on that because I think the detail will come through in the following appendix, Appendix 4. So this came from the conversations we had just around how do we ensure that we make best use of our time as a partnership and also understand where decisions and issues are being raised elsewhere within the system so that we're really clear about our role as an ICP compared to what's happening elsewhere, and that we don't forget our core purposes, which are around shifting resources towards prevention and implementation of the integrated care strategy, and those being those two things that we need to bear in mind through the work. So there's some draft principles there to consider around agenda items, which covers off some of those issues, but also is around ensuring that the papers have a really clear ask of us when they come, that we have for information items as we need them. There was a reflection that sometimes it is necessary to have items for information only, but to be really clear why they're coming for information only, and to focus the majority of our time on those things where we can take action and make change. So they're the draft principles. I'd appreciate very much any comments or otherwise agreement with those principles. There's also the agenda framework, which, as I said, follows on to the draft agenda that's then attached in the previous appendix. Thinking about the items that we need to cover on the agenda each time. So we discussed that it would be valuable to have an action log taken and then reviewed at each of the meetings. And as we were discussing this, a consideration that actually we could ask whether the Joined Up Care Derbyshire Executive Group would be happy to monitor that action log and to ensure that updates were ready and work was being progressed. Just to note that we're aware that the Joined Up Care Derbyshire Executive Group is currently, as Nikki mentioned, just reviewing its role. Then to move on to the integrated care strategy, key areas of focus, so that each meeting we would have an update, as we have been doing, from each of the themed areas. But importantly, to ensure that those updates cover the work across organisations and include any of those areas for escalation, any issues of unblocking. So, for example, as Jane has raised today around the information sharing, so that we are able to see where there's actions we could take to further progress the strategy. Then other themed areas, so areas that either the chairs or the Joined Up Care Derbyshire Executive Group feel should be coming to the meeting because they're sufficiently important and they relate to the system. And again, these should be brought for action and consideration as to recommendations to the partnership. The enablers section, which would relate to workforce, IT, the data sharing issues, any of those enablers that could either really progress our work or hinder it to come for those conversations. And then finally, the governance section, which would relate to terms of reference, but also any update reports that we need to receive, particularly from the Integrated Place Executive, or any other issues raised from our health and wellbeing boards or from the Integrated Care Board as well. So that gives a structure, and you'll see in the forward plan that the forward plan for the year is broken down in that way. There's also a proposal around identifying and requesting agenda items for the ICP, and as mentioned, really putting either the executive group or the chairs group that oversight around what's coming forward to make sure that requests are made in a timely way so that papers can be produced and considered, and there's visibility for the execs of those papers before they're coming through for publication. But also to ensure that we're really clear why items are coming. So that's the principles, and then there's also attached Appendix 5, which Alison has produced for us, the guidance for authors. So it reiterates some of those principles for those people who are writing papers who perhaps haven't attended the partnership meetings, to give them the context and the guidance around the information they need to be including, and also the process to go through for the consideration of the papers. You'll note in the previous appendix that the route for agenda setting managed to wipe some of the information before it was actually put into the PDF, but you'll be pleased to know that Appendix 2 of the final appendix does have the boxes with the information and the arrows in, just to give that direction as to how the decisions would be made and the papers requested. This is in particular response to one of the issues that was raised in our development session. So really the ask of the partnership to either make amendments or comments on those, or to approve those as a way forward, obviously to test and to see if that's working and to review. Thank you.
Thank you, Robin. Thank you, Nikki. That's really helpful, really useful input. And also thank you to Alison Wynne for pulling a lot of the information together from the development day. And so I think what I'd like to do is just take any potential response. Well, hopefully there will be a response, not potential response, but actual response to this report in terms of the recommendations as set out in front of us, so we can structure our discussion of this, if that's all right. So, I mean, if anybody wants to come in with a sort of left field comment that doesn't seem to come under any of those categories, we are not rigid here. But just, and that's fine, but just to proceed according to the recommendations then. So we are asked to note the overview provided the development session held on the 16th of 2024. Did anybody have any particular comments on those, or any objections to the way or any sense that it didn't capture what was said? Are we happy with that overview? Okay, thank you. There's only one point I'd make, Alison, and I think it's in that overview. You'll have to forgive me if it's somewhere else in the report. I read it all last night. There was an expressed desire to have more meetings in private, and I just want to say to the meetings, I have discussed this with our constitutional officer, and apparently this isn't going to be not lawful in his opinion. We could have one-off ad hoc development sessions, and I know that Nottingham have assemblies as such, but the Integrated Care Partnership, whether we like this or not, is by statute formed as a meeting where we have discussions that are in public. So that was just a point that to rule out that kind of point really that's in there. Any other comments on that? Thank you. Yes.
So, Chris Pienaar, VCSE representative for Derbyshire. So just a couple of very quick points. The one is just the really important need to keep emphasising co-production from start to finish. We do raise it a lot because it's so critical, and that should appear somewhere there. In discussion, we felt that ensuring that the system is enabling the best use of the strengths of individual parties is something good to put into those notes from the development meeting. Then there is, coming up in March, there is a review at the executive of the VCSE role and looking at the impact assessment that took place over the last year. And I think that will feed back into this. Thank you.
Okay, thanks for highlighting that. And I think we can incorporate that, Alison, can't we? Yeah. So thank you for highlighting that. Thank you. And then we have the table. So 2.2, consider and discuss the proposal set out in 4.4 before 4.7 in this report. Now, I know you'll have all read those. So are there, is there anybody who wants to, so I think what we're asking today, we'd like an approval of that set of proposals for action and consideration. Would anybody like to comment on those today? Jim, are you tempted?
I moved. It's a bit like being in an auction, isn't it? I think I've bought something. I mean, I support the recommendations. I think they look fine to me. Thank you.
That's nice. It's nice to have a motion from the floor to support, to move the recommendations. So, no, quite all seriousness, this is our development day. This is your input. This is your ICP. It's an absolute partnership. It only works if people are willing and able. And I know the capacity is an issue, but it certainly won't get off the ground, won't keep moving forward if we're not willing. So it is important that everybody is quite, absolutely happy with that series of proposals. And are people in the room happy with those series of proposals? Yes, yeah. Okay, thank you. I just wanted to labour that point a bit, just to make absolutely sure, because we did give our time for a development day, and I don't want it to just be some sort of formulaic thing where people say the right things and don't buy into it. Thank you. And then 2.3, to agree the next steps required to support the ongoing development of the ICP. Robin, do you want to comment on that? Because that one's quite... Is there anything in specific you're thinking of?
So I think it's very much working through those actions that we have in the table, and then as Nikki was noting, that need to review what we've achieved, to be really clear about being positive about what we have achieved together, and then to be clear whether there's any implications for the strategy, whether we need to make any amends or any changes to our plans in relation to the strategy for the coming year to 2 years.
So would anybody like to make any comments on that? And is everybody happy to subscribe to that, those principles, those aims going forward? Thank you very much. Thank you. And finally, to consider this agenda framework and principles and guidance for authors. We have looked at that. I think it's really helpful. Any comments on those at this stage? No? Do we all accept them in principle? I mean, I think what I would say with those is that if anybody does have any sort of minor points, then I'm sure they could be fed through to Alison outside and after the meeting. So do you have any other comments on this report? No? Right, well, that's excellent. Well, thank you very much. Just remains to thank Nikki and Robin again for their work on this, and also, and perhaps particularly, Alison's work as well. Thank you. So finally, last but no means least, and much deferred, I think, it's long awaited, shall we say, not much deferred, but long awaited. We have Chris Viner's report on the Derby and Derbyshire Health and Care Research Strategy. Thank you.
Thank you, Chair, and I won't keep going into a huge amount of detail around this report, but I think it is important that we recognise that a thriving research environment for health and care is incredibly important in terms of the people that we have working in our services and recruiting high-quality people to our services. It's incredibly important in terms of maintaining high-quality services themselves. And thirdly, and most importantly, we know that where we have a thriving research environment, you get much better health and care outcomes within the community that we serve. So this report is basically presenting a health and care strategy that has been through multi-organisational development, signed up by most of our organisations across the system. Has been a delay in getting it through to this particular meeting, Chair, but we are looking for us to actually get some approval from this meeting for this strategy to proceed. Having said that, we've actually taken the liberty already of moving into the implementation phase in the wider environment, Chair. We are looking at the further development of the network, and myself, Robin and Ellie, amongst others, were at a meeting with the Derby University this morning, where we were looking at trying to strengthen the academic links that we have right across our community in order to progress this strategy.
Excellent, Chris. Thank you. It sounds extremely interesting and significant. Thank you. So the recommendations we have are, I know we're only noting it, but we do actually have 5 minutes, so I'm going to run through quickly the recommendations. Is that we obviously received the report and that we will support the strategy and its intent, and to develop an implementation plan as the next steps, and perhaps to consider receiving future dates and progress. Does anybody want to comment on those recommendations or the report? Penny?
I massively agree with those recommendations. I was just wondering, Chris, how NIHR was how you envisage moving forwards with Derby University involvement and NIHR. Will they be working together? Because a lot of general practice, for instance, are already signed up to NIHR research studies and programmes. So I was just interested to see to hear how that might work together. Thank you.
Short answer is yes, we will be working together, Penny. Links are already there and in place. The university is linked in as well to NIHR. I don't see it as being an area of concern. It will continue and it will progress.
Thank you. Any other comments? Chris? Thank you. Did you want to respond to that, Chris?
I just note, Chris, that it was an active part of the conversation this morning that we had with the university, with the need to focus on actually real impact. And I think it's recognised that that will be key to going forward, taking some what might be small pilots and then building those into larger pieces of work. Earlier on today in this meeting, we had the conversation, didn't we, around speech and language services. They've started off with a small pilot. They're looking at expanding that work. I think we need to build on that kind of approach and use that to drive real learning to improve services locally and nationally.
Thank you. Right. Thank you very much. If there are no further comments, I assume we're all happy to accept the recommendations as printed. Thank you very much. And I think, is there nothing else, Alison? No, right, that brings us to the end of this meeting. Thank you very much for your attendance and all your input, and we'll look forward to seeing you next time. Thank you.